Welcome everybody. Thank you for joining. Apologies for the slightly late start. We're going to give it one more minute to allow everybody who's in the waiting room to join, and then we'll get started. Please feel free to introduce yourselves in the chat as you join. All right, welcome everybody. My name is Sarah Hess and I work in the Health Emergencies Program here at WHO in Geneva. I'd like to welcome you to this webinar, which is a discussion on SARS-CoV-2 testing. We have a number of WHO experts on the line today to both present and to answer your questions. If you have questions during the event, please do put them into the Q&A function on Zoom, and we will try to address as many of these as possible after the presentations. Just a quick reminder, of course, that we are streaming this to YouTube, so the recording will be available there, and we will be able to share a copy of the slides after the event with those who have registered. As always, we have interpretation into French, so you should be able to access that if you're joining from your computer or phone. So without further ado, I would like to welcome our speakers and our panelists. We have Dr. Maria van Kerkhove, who is the technical lead for COVID-19 here at WHO. We also have Dr. Marc Perkins, who is the pillar lead for labs, testing and diagnostics within the WHO COVID-19 response. We have Dr. Jane Cunningham, who is a specialist in particular in rapid testing for infectious diseases, and she is also supporting the lab team in the COVID-19 response. And we have Dr. Sebastian Cognac and Dr. Celine Barnadas, who are both experts in public health laboratory strengthening. So Maria is going to start with an introduction. So Maria, over to you.
Thank you so much, Sarah, and thanks for having us on the EPI-WIN platform today. I'm just going to take a couple of minutes to introduce Marc, Dr. Marc Perkins, who will give the presentation. So I just wanted to start with a couple words about the global situation. I don't have any slides to show this, but you can look on our website and you can see the latest epidemic curve. You can see the fragile situation that we're in. In fact, we're starting to see an increase in case numbers again after several weeks of decline. And not only that, we're starting to see an increase in deaths across a number of regions in the world. At the global level, those trends hide the heterogeneity that we see by region and by country. And just looking at some of the data overnight, we have exponential growth, really sharp increases in cases in more than 20 countries across all WHO regions. And this is a dangerous situation to be in because we have tools. We have tools right now that can prevent infections. We have tools that can prevent somebody who is infected from spreading to somebody else. And we have tools that can prevent people becoming sick and people dying. Those tools include public health and social measures. They include testing. They include early clinical care provided by supported, protected health workers with access to therapeutics to care for their patients. And it includes vaccines. And right now we have a really inequitable distribution of not only the vaccines, but also of testing and of therapeutics and of PPE. So today we're talking a little bit about our testing strategy and how we develop that testing strategy. We seek input from many people all over the world, not just our technical expert networks who we're so grateful for working with us, but from end users, from patients, from medical professionals, health and care workers, from our CSOs. And I know that we specifically set this up today to discuss with CSOs. And again, Sarah, thanks for that opportunity to provide this forum. But I do want to say one thing about testing, and Marc will go into this. Testing is only part of the comprehensive strategy that we need to control COVID. It's absolutely essential. We need to know who is infected. We need to know where the virus is spreading so that we can take the appropriate action. We can use our resources most effectively, and we can support governments in regaining control over COVID-19. But testing has to be accessible, it has to be reliable, it has to be affordable, it has to be linked to public health action, and ideally, it needs to be easy to use. So there are new tools. We have PCR-based tests, but we also have antigen-based testing, many of which are reliable, some of which are approved by WHO EUL, that can be used by many people outside of labs and clinical facilities if they're trained and according to national law. So here we are going to give an overview of the different testing strategies depending on the intensity of SARS-CoV-2 circulation and how best to use those resources. And then we'll have a discussion amongst this great group of people from WHO and with all of you. So I think with that, Sarah, if that's okay, I pass to you, or I pass over to Marc.
If Marc's ready, we can pass directly to Marc. Marc, are you there? We don't hear you, Marc.
Can you see my screen?
We can see your screen and we hear you now. Thank you.
Great. Thank you very much for the introduction, Maria. I'm going to be talking for about 20 minutes on the diagnostic strategies that are how they change with the stage of the epidemic that you may be in at any time. And then we hope that this will generate a bunch of questions, because we're really here for the conversation. We have some of my colleagues online with me to help them answer those questions. Now, if I can just get my screen to work. Yeah. So as Maria said, testing is absolutely essential to understanding where the outbreak is and following it and introducing social and public health measures to fight it. It is one of the things that is most critical. And of course, people have heard the Director General say test, 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 but he finishes the sentence so that appropriate clinical care can be administered, and contact tracing and other things that will help stop the infection can be put in place. So diagnostic testing is not an intervention in itself. But it can lead to interventions that will help disease control. And this is the goal, is to have accurate testing used in the right way, in the right populations, at the right time, in order that people can get care and contact tracing can be put in place, and the opportunities for transmission can be interrupted. So we have recently developed some guidance. And the main author in that guidance is on the line with us today, Lisa, on how to use rapid diagnostics and PCR in different settings in different stages of the outbreak. And we have another document coming out in the next week or so that is specifically on antigen detection rapid diagnostic tests and their use in COVID.
Marc, I'm sorry to interrupt you, but your audio seems to come in and out a little bit. It goes very soft and then gets louder. Is there a way you can maybe move closer to the microphone? Sorry about that.
I can certainly speak more loudly and closer to the microphone if that helps.
Thanks very much.
Are you hearing me okay now?
Yes, it's fine for now. Thank you.
Okay. So to generate these reports or these guidance documents, we follow the WHO handbook on guideline development, or use emergency mechanisms to when the guidance documents can be developed, need to be developed urgently. But these are always done in coordination with partners and expert groups and with our member states who we represent and are working for, in fact. WHO always draws on external expertise through its reference laboratory networks and through members of the ACT Accelerator, including civil society and open forums like this one, to help inform their policies as they're in progress of being developed. A guideline development group is being established for WHO procedures on diagnostics as we speak, and this will further strengthen our capacity to develop appropriate guidance documents that are weighted. We have a reference laboratory network of some 24, 25 laboratories around the world. These laboratories have been meeting with us weekly since the start of the outbreak and helping us draft, edit, and improve our documentation and guidance policies. And you can see that there are, this is actually, I'm not sure about this map. I think that'll move on. We have from the Lyon group, Celine, who's on the line, has been really active in establishing a laboratory community of practice, bringing in people to discuss in forums like this one or technical fora, discuss elements of diagnostics and COVID management. And we've had, obviously, as you can see, over 7,000 participants in these webinars, and from 182 countries. So strong engagement. Now, everyone knows that, I suspect recognizes the chart on the right, which is a chart of what happens during the course of early infection, where, as you see, the symptom onset is the red dotted line. And before then, probably for as much as 2 to 7 days before the symptoms begin, there can be measurable virus in the respiratory tract that can be detected with PCR or antigen detection. And then it falls over time so that PCR and antigen detection tests become negative within the weeks, days to weeks after infection, after symptoms start. Antibody tests, as you see, are too late to be used for diagnostics and clinical management. As you can see that IgM and IgG both increase around starting in week 2 and become easily measurable in the 2nd or 3rd week of illness, by which time most people have neutralized the virus and are on the road to recovery. So the antibody detection tests can be used to understand the attack rate in the community and to help understand whether or not an episode of disease that was not tested at the time could have been COVID. People infected with SARS can transmit with or without symptoms, with SARS-CoV-2, with or without symptoms. So there are a number of patients, individuals who become infected and are asymptomatic throughout the course of their illness, of their infection. Most infected people transmit the virus around 2 days before they develop symptoms and up to 9 to 10 days after symptom onset. People who develop severe disease can be infectious, of course, for longer, especially with their extensive pulmonary damage. And immunocompromised individuals, such as severe HIV, AIDS or severe HIV infection, can shed virus for months. Symptomatic persons infected with SARS-CoV-2 are 3 to 18 times more likely to transmit the virus than asymptomatic persons. I think it's worth stressing that there may be a large number of undetected asymptomatic individuals in the community who are infected, but they are contribute much less to the ongoing transmission burden than do the people who have symptoms, in part because of the symptoms, the cough and the sneezing, etc., help transmit the disease, but also because of excuse me. Are you able to hear me well still?
Yes, we can hear you, Marc.
Okay. So the situation for COVID testing changes over time in terms of what decisions one might make. And we've got a schematic here with 0 cases reported in a phase, or sporadic cases, clusters of cases, and community transmission. Simply, these are degrees of transmission in the community, and you might want to take different care at different times and use even different test methods in different settings because of some specific specificities of these tests, which we'll discuss in just a moment. So transmission scenario in no cases, you do have laboratory services required during that period to detect imported cases or prevent early clusters, excuse me. In this setting, you don't want to have false positive results, because these, and when you go from no cases to even a single case, it's important news in the community. And especially if you're an island nation, for example. But you need to make sure that you're not working up the health system and starting contact tracing on patients who are in fact false positives. That's why RT-PCR is best used in this scenario. It means then that testing capability needs to be in place even when there are no cases notified, because if you are in fact an island nation like New Zealand, you won't, unless you're testing, you won't know that there are when transmission has begun. Sporadic cases are the next stage in the transmission and the epidemic. And here, the aim of testing is to prevent onward transmission through case finding, testing symptomatic people and asymptomatic contacts of confirmed or probable cases, treating and isolating people who are confirmed or have probable SARS-CoV-2 infection, and tracing contacts of confirmed and probable cases. Again, confirmation here in this setting would be with PCR testing. Clusters of cases is the next stage, a worrying progression, especially as clusters may break out in vulnerable populations, such as in nursing homes or long-term care facilities. Here, the aim again is to stop transmission, onward transmission, by testing both symptomatic and asymptomatic confirmed cases, the contacts of confirmed cases, and to treat and isolate people with confirmed infection. The goals are the same, and the testing again should be done by PCR. PCR may not be widely available, in which case you use the tools you have and make sure that you are always cognizant that no tests always give perfect results, and repeat testing may be needed if you are uncertain that the test results are correct. Community transmission is when there's a high incidence of locally acquired and widely dispersed cases in the last 14 days. So the aim of community transmission of the scenario of testing strategy in this scenario is to try to interrupt as much transmission as you can and get the disease under control, primarily by testing symptomatic individuals. And asymptomatic individuals may be tested if they're contacts or probable cases, if capacity allows. But in no way should we forget that the priority are symptomatic persons who are infected and who contribute the most to onward transmission. It's important to carry out outbreak investigations, especially in vulnerable groups or areas where there can be super spreading events. When there's limited capacity, which there almost always is in lower and middle income countries, you should prioritize testing of suspected cases, people who meet the case suspect definition. There also then those who are special attention should be given to those persons who are at risk for developing severe disease, who have comorbidities, for example. Also health workers, inpatients in health facilities, and enclosed settings such as schools, prisons, or long-term living facilities. In this setting, either antigen detection or PCR can be used. The diagnostic tests we've already gone over briefly are nucleic acid amplification, which amplifies the genetic material, and these can be extremely sensitive assays, detecting a few hundred viruses per milliliter of respiratory tract fluid. These are so sensitive that they must be also extremely specific so that you don't have any false positives, and they are, if done correctly, extremely specific. So as a marker of this, when the disease control was finally reached in Wuhan, in China, the government did a screen of the entire population with PCR. Some 10 million people were tested, and they had 300 positive results. And they did contact tracing on all of those and found 0 cases of transmission from those individuals, and they were all asymptomatic. So that either means that the test is perfect and there were only 300 cases in Wuhan, or that the test was 99.9997% specific, which is extremely high. And if you had used an antigen detection test with a 99% specificity, that 99% of all negative cases would be truly called negative. You would have, in that same situation, had 100,000 cases in Wuhan that needed contact tracing and disease management, all of whom perhaps would have been false positives. Antigen detection, however, does give you the advantages of speed and much greater simplicity of use than PCR. PCR needs to be done in a laboratory setting with trained personnel, whereas antigen detection could be done at the bedside, can be done with people whose only training is, only medical training is doing or reading these assays, and can be performed very quickly to drive decision-making. Antibody testing, as we described, is useful to see retrospectively who had infection, but not useful to detect new cases. So how should testing be prioritized? Well, WHO recommends that all individuals who are suspect cases they're suspected to be infected with SARS-CoV-2 be tested with a NAT or antigen detection test, regardless of their vaccination status or COVID-19 disease history. Neither one of which makes you completely invincible against a repeated infection. Asymptomatic individuals, on the other hand, should be tested also with one of those two methods if they are at higher risk of COVID infection and if the resources are available to test them. So one would optimize testing and the impact of your testing by starting with suspect cases, and after you've tested, put up testing capacity to make it possible to detect all the suspect cases, would you then expand testing to include asymptomatic individuals? And then lastly would be people who had no known exposure. In some countries or settings, there aren't enough resources to test everyone who meets the suspect case definition. And in that setting, we recommend that you prioritize people at the risk of developing severe disease, healthcare workers, inpatients in health facilities, and symptomatic individuals in closed settings. It's also important to expand a decentralized capacity to improve access to testing so that all the tests don't have to be done in a laboratory setting, such as in the photograph here. Antigen RDTs, let me just change my screen here. This is a picture of the virus or a schematic of the virus. Just to remind you that there's RNA, positive stranded RNA inside in the coiled loops. And then they are surrounded by an envelope with proteins sticking out of them. And those proteins can be detected by lateral flow tests that have antibodies on them that are engineered to detect those proteins and bind them. So the antigen RDTs tend to target the nucleoprotein, that's the N protein, and that's associated with the RNA, or the spike glycoprotein, which is on the surface. So antigen RDTs can be used in many settings that PCR cannot be feasibly used. Based on published data, results are most reliable during the first to 7 days after onset of symptoms. So these are not, it is not useful usually 10 days or 12 days after illness, after onset of illness. The likelihood of a positive result is much higher in the first 5 to 7 days. Shelf life, these are laboratory reagents, even though they may be simple to use, and they can be destroyed by heating or even keeping it too cold. Shelf life needs to be paid attention to. They're usually 12 months. In storage conditions of maximum 30 degrees C will pose challenges for some supply chains in many settings. End users should be trained, and WHO and FIND have provided training materials. So 7% of all or more of all the cases reported to WHO have been in healthcare workers. So it's been a hard hit community, even though they understand the risks and may have better access to PPE than other individuals. They're still a risk cohort. And testing is a key strategy to manage not only an existing outbreak, but to do surveillance in this community for repeated infections. I'm going to skip this slide, and I'm going to skip this slide. And I've already talked through false positives and false negatives. So we get a lot of questions about COVID testing in the context of international travel. And we follow a general logic, which is that people who are engaged in international travel are not any more likely, in fact, are less likely than the general community to be infectious or to be infected. So symptomatic individuals are usually screened out, or may be screened by even asymptomatic passengers may be screened prior to getting on airplanes. So testing on arrival is not encouraged, and we don't encourage that primarily because it is not a priority resource. It may be useful in some settings of small island nations to reassure the community. But if one is setting up testing in your community, you should think first of where the risks, who are the risk patients, and prioritize the high risk individuals, not necessarily international travelers. So as we've said, the type of testing and the volume of testing will change depending on the stage of the outbreak. And obviously, when there's low case numbers, as in no reported cases or sporadic cases, the risk of false positive results becomes more dramatic and the impact greater. So if you have only 2 real cases in your community and you detect 20, it gives you a lot of contact tracing work to do that is not necessary because those are of the false positives. So we recommend PCR in these low transmission settings, whereas obviously in most countries, PCR needs to be supplemented with RDT use, which is especially effective in community transmission settings. I have listed here resources available on WHO website. And just a final note before we close this initial talk is that there's been a lot of discussion about variants, which are striking in their propensity to or capacity to take over as the major form of the virus circulating in the community in just a number of weeks. But the variants, you can be protected by variants using the same measures that you will use without variants. So wearing a mask, keeping your distance, washing your hands, ventilating and opening windows, and coughing or sneezing into your elbow, and of course, vaccination. Thank you.
Thank you very much, Marc, and for the presentation, and Maria for the introduction. So we have some questions coming in. And again, I'd like to invite those who are listening to submit their questions into the Q&A, and we will try to get through as many of those as possible. As mentioned earlier, we have a number of WHO colleagues on the line who are here to answer questions and join the discussion. So actually, one of the first questions that come through is related a little bit, Marc, to your last comment on the variants. Nagwa is asking, is there data on the change of transmission dynamics related to the different variants? And I wonder, Maria, maybe this is something you'd like to start with, and then we'll carry on.
Thanks, Sarah. And then the team can come in and talk about our ability to detect with available diagnostics because of the variants. We do get a lot of questions of, do our countermeasures continue to work? So as you know, we're tracking how the virus is evolving. It's a virus that evolves. This is natural. This is expected. And there are several virus variants that we're tracking around the world. We have 4 variants of concern: the Alpha, Beta, Gamma, and Delta. The Delta variant has been detected or reported in more than 100 countries now. And it is more transmissible than even the Alpha variant, which was the B117 variant, detected around November, December, really starting to spread in November, December last year. The Delta variant is more transmissible, but what we're trying to better understand is why. And so there are several mutations that have been identified. So the variants are a clustering of mutations, several different mutations in each of the variants, and they give different properties to the virus itself to be able to, for example, adhere to the cell, the virus adhere to the cell more easily and infect the cell more easily. There are a lot of studies that are underway. Those studies are looking at, the modes of transmission and the way it spreads between people. We're not seeing any differences in the way that the virus spreads between people. The virus still mainly spreads between people in close contact with one another through these infectious particles that could be larger, called droplets, or smaller, called aerosol. They could also spread further than this conversational distance, or the 1 meter, 2 meters, in specific settings, like enclosed spaces with poor ventilation. So this is why we recommend this comprehensive strategy to take measures to keep yourself safe. We don't see any data that suggests that the infectious period is different for the Delta variant or for any of the variants of concern compared to the ancestral strain of SARS-CoV-2. There are a number of other studies underway that are looking at surface persistence, that are looking at persistence in the air. We don't have data yet back on some of these studies, but from all the information that we have so far, the virus still spreads the same way. It's just more transmissible, meaning if one person is infected with the Delta variant, they can infect more than the ancestral strain. So I hope that's clear. But I do want to say with the diagnostics, I'll pass to Marc and the team, but we know our countermeasures work. So far, the vaccines work against the Delta variant. The vaccines are aiming to prevent severe disease and death. And we know that there may be some reduced efficacy, but they still work against severe disease and death. So when it is your turn, it's important that you get vaccinated. And maybe Marc can comment on the diagnostic use or the diagnostic performance with the Delta variant.
Yes, thank you. Yes, there can be mutations in any part of the genome, the viral genome, and some of those mutations can happen in the places where the primers and probes for PCR, for example, are binding and can affect binding and therefore the sensitivity of the assay. And some settings, this assay completely stops working and cannot detect the virus if there's a significant enough mutation or if it's just the right place. So this is always, as happens in every viral infection, especially in RNA viruses, because they have greater mutation rates than than DNA viruses. So it's always something you track and wonder about. And recently, there's been reported in non-peer-reviewed literature from two laboratories, one in the United States, one in Italy, assays that were unable, RDTs that were unable to detect specific mutants that that had previously been detectable because of the mutations in the proteins that were being encoded by the RNA. So these can make the molecular and antigen tests not work. But this is one of the reasons why one needs to be cognizant of this possibility and always worry about the results that don't make sense to you and think about repeating them. But in general, these mutations have been uncommonly associated with lack of performance of testing. So generally, the performance of testing works. Sometimes there are mutations that are even to our advantage, such as the S gene dropout at 79 and 80 amino acids. That gene dropout pattern signifies one of the variants and can be used as a detection system.
Thanks very much, Marc, for the answers and the clarifications there. Interesting question coming from Chris. While every country has different circumstances and scenarios, which countries are doing well with testing and why? Who from our panel would like to take that question?
I'm going to ask our panel to turn their cameras on, if they will, so that we can see them and see who we can perhaps get some answers. So I don't know if Celine or Sebastian would like to comment on that. I mean, let me just say that all countries are doing well and doing poorly, and I think that there's a lot to learn through this. So even if a country isn't doing as well as possible, it could always be turned around. But I do want to say, it goes back to what I said in my opening. Your ability to do testing, is based upon capacities. It's based upon access to equipment, to individuals who can carry out those tests. And even in particular, the antigen-based tests that we mentioned, access to affordable, reliable tests. So it's not just a matter of the will, it's a matter of making sure that there's the way that they have that. So I'm not sure who on the panel wants to. I see Celine smiling, or Sebastian smiling. Maybe one of them want to cover.
Thanks, Maria. I can try. It's a hard question because the question is which countries are testing well. Well, it could mean many different things actually. And I think for us, well, it means not only that they are testing in large volumes. It's not a quantitative approach. It's that the testing is done at the right time, in the right way. So it's a strategic testing that is done. I mean, so basically the testing, a country that would test well is a country that would really have a very good strategy according to the resources they have at a certain time. And we know that the resources are evolving. We know that the disease of the prevalence is evolving over time, which means that countries should constantly adapt their testing strategy in real time. And so we don't want to rank the countries. For instance, just comparing the number of tests that are done, we try to see what are the gaps in the testing strategies and whether the testing procedures and strategies correspond to the resources and to the needs and are adjusted in real time. And to do so, we, of course, provide technical assistance to countries through our regional offices, through our country offices, to help them select the best test or the right test corresponding to the situation. We provide also training, and we are also trying to assess the capacity of the laboratories and the quality of the laboratories. We provide panels to do that. And we can say that when we did this exercise, providing panels of viruses, we saw that most of the countries, in a very large number of countries, are testing very well. When the diagnostic capacity, the quality of the testing in the laboratories is very good. We don't have yet such program, such mechanism to monitor the quality of the antigen rapid test, but this is something we have in mind to make sure that we could also measure the quality of the testing when countries are using Antigen RDTS. Over to you, Sarah.
Thank you very much for the intervention. I am now actually going to hand the floor to Chase Perfect, who is one of the civil society representatives for the ACT Accelerator. And Chase is going to make a brief intervention. So Chase, I have allowed you to talk, so you should be able to speak now.
Okay, great. Can you hear me?
I can.
Awesome. Thank you. Thank you so much. I just wanted to take the opportunity to introduce the civil society delegation to ACTA. Some of you may be familiar with ACTA, and I'll try to add some links in the chat about the delegation, but also maybe you could provide some links in the chat as well about ACTA. And just to say that there are civil society representatives who are participating in working groups as well, in pillar calls and in the facilitation council. So I just wanted to share that information in the chat. I put my email address, and you can connect with me there and we can share more information. So just wanted to flag that. And real quick, I wanted to just highlight the point, very brief on the part of the delegation, and that's this gap that we're realizing is emerging between some of the policies and tests available in the richer countries, so to speak, and in the rest of the world. In particular, with the EU, we've seen that the list of antigen tests that are approved for travel certificates is dozens of tests long, and that these tests are being used in low prevalence asymptomatic populations for travelers. I know that's not in line with WHO, but the interesting part there is just that the issue of using this number of tests in that kind of population creates a sort of gap in regards to the fact that the WHO has approved 3 tests so far, and that the challenge of using all of the donor funding, particularly the funding from Global Fund and the C19RM, that can only buy the 3 tests approved by the WHO, and only 2 of those produced at scale, and those 2 being quite expensive for scale as antigen test. That our general question is like, how can we kind of reconcile this, the number of tests approved in the EU and the WHO? Not saying that either is right or 100% right or 100% wrong, but that there is an emerging gap in terms of which tests are approved and how different structures are introducing corresponding policy. So I'm going to put that question in the chat because I tried to summarize it briefly. And thank you for the time for this intervention. Thank you.
Thanks very much, Chase. Maria, do you want to respond to that at all?
Yeah, Chase, thanks very much. And thanks for the work of the CSOs in the ACTA groups. We've had a lot of really good engagement with you, and we appreciate the feedback that you provide and the feedback of all CSOs. I mean, we're really trying to do, and Sarah, you're critical in this, in the work of EPI-WIN of really engagement of CSOs. We try to include CSOs in all of our technical guidance reviews and updates and discussions because it's quite important. The point that you raised about EUL and pre-qualification is a good one. I don't think we don't have anyone on our team present here to discuss the issues related to the review. There are several, I know that there are several antigen-based products that are undergoing review. The challenge that I know of, and I'm not a PQ specialist, so others may want to come in here, is about the information that is provided to do that review. We need to have a full dossier of the data to be able to carry out the review. And so there are several that are in the pipeline. I know that there are several that we have not received the full dossier on. But there are, the ones that we have approved themselves. But cost is also a massive issue that Chase has brought up. There's a lot of snake oil out there, let's say, in the realm of testing. Hundreds and hundreds of tests that are out there that are not performing well, some of which are very inexpensive, and they're really not, providing the intent that we need them to provide to know who is infected, and so that life-saving actions can be carried out. So there's that balance that we're trying to raise there. So I'm not sure if anyone else on the team wants to comment on that as well.
Yeah, I guess, Maria, I would just add, I agree with you. I think our PQ colleagues are probably best to comment on this, and perhaps something that might be useful would be for us to put together a table that shows the differences between the WHO PQ process and requirements compared with the EU one, so that then it can become a little bit more clear why our procedures are taking longer, or why we may have rejected certain or not approved certain tests that have been approved through the EU processes. So I think that's something we can take up after this call to make it really clear just what the differences are.
Thanks, Jane. Thanks, Maria. Marc, very quick question for you. Did we hear correctly that there will be a new document published this week or next week on RDTs?
Yes, I don't want to nail myself to the cross about the date exactly, but we're in the late stages of development of a document driven by Jane, who was just speaking, but with input from dozens and dozens of individuals inside and outside of WHO. So it's undergoing meticulous review at this stage, and this should be out relatively soon.
Thanks, Marc. A couple of questions about PCR testing. What do we know about the false positive rate of PCR testing? If an individual is PCR positive, but their infection has long been resolved, is this a true positive or a false positive?
So there's not a very clean answer to that. In general, there are two types of false positives with PCR. There are errors that the operator makes while performing the test that makes them become falsely positive, or there's some cross-reacting molecular material in the sample. This may, or I guess thirdly, also there can be what's called primer dimer formation, so that the kit itself is engineered badly. The molecular engineering is faulty, and it finds itself to be a target and tries to amplify itself and gives you false positives. Those false positives tend to be easy to spot because they happen a lot, and they usually are picked up early in manufacturing and never make it out. The most common problems are user errors. You're pipetting small microliter amounts of fluid, etc. It's precision work. So it's impossible to make mistakes in that part. It is the operator it's intensely operator dependent. That being said, in good hands, they are very specific assays in general. So if you have a person, probably a more common reason for false reactions than I mentioned before is sampling. That your test is only as good as your sample, and sampling is sometimes difficult to do well, or people don't like it and therefore don't do it. Don't allow scraping within areas or what have you. So these are the main causes of false results. They tend to be very specific, however. The test was working yesterday and gives you positive results today that you're concerned about. Repeating them makes sense because of the likelihood of the possibility of a user error. But it's also possible that you would have had very good sampling on week 1, and then you didn't sample very carefully on week 2, and it became negative. And then in week 3, you tested them again, and it was positive again. And that is more likely to be a sampling error than anything else.
Thanks very much, Marc. I'm looking at the time, and unfortunately, we're about 6 minutes from the end of the webinar. What I'm going to do is I'm going to ask my colleagues on the call to please have a look through the question box and try to select 1 or 2 that you feel are relevant to a broad group that you would like to address, because there are a large number of questions there, but we'd like to get as many of the important questions discussed today. So I wonder, Celine, I'm going to put you on the spot. Have you identified any questions that you would like to answer? I can come back to you if you prefer. I don't hear you. No. All right, we'll come back to you. Maria, what about you?
So I'm looking at, I'm trying to answer some of them as you are speaking. So I've done a few that are there, and they're very good questions, by the way. There's a lot of questions around sort of how much I'm gathering is like, how much testing is enough. And these are really good questions. What are the benchmarks that are set? So we set some benchmarks to help us understand how much testing is actually happening in a country, and help us so that we can interpret the data that's actually coming to us through all of the surveillance systems. So when a country tells us they have X number of cases reported, or they have a percent positivity of X percent or something, we need to know, to evaluate that, we need to know how much testing is actually happening. And so we set some benchmarks of saying, what is adequate? This is not an answer on how much is enough or how much should be done at a minimum. So what we've currently set was around adequate is around 4 tests per 1,000 per week, which sounds really low. And it is, but remember, we're doing global discussion right now. We're talking at a global level. The guidance that we set is also different than the policies that are set in individual countries. What we do is we aim to say if all countries could start with suspected cases and test all of their suspected cases with PCR-based testing, with antigen-based testing, I'm trying to get an accurate number about what percent of the world's population that would actually be. Because if we could do that and we can start there, and we carry out the isolation and the contact tracing, then we can actually eventually pick up with those individuals who are asymptomatic or even pre-symptomatic, because those individuals are already in quarantine and they can't spread the virus even further. So we set some benchmarks there. Having said that, we also have several calculators and tools that we have issued to help countries determine how much supply they need based on the current situation they have, the capacities they have, the equipment and the training that they have for either PCR, antigen, or whatever the test. It could be for PPE, it could be for O2 as well, to help with surge capacity, to help with stocks, So those are other types of calculations that we provide. I'm not sure if the others want to come in around that, but this is a question that we actually get a lot. How much is enough? We get this question for sequencing too. We get this question for O2 and for PPE and all that as well. But others may want to come in on that.
Thanks very much, Maria. I'm going to hand to Sebastian now. Any pertinent questions you'd like to address, Sebastian?
Yes, thanks, Sarah. I was starting to reply in the chat. So there is a question on how to explain negative RT-PCR in a high community transmission of COVID-19. I think it's good to remember that many other pathogens can trigger COVID-19-like symptoms, and it's very important to keep or to maintain some testing capacity for other pathogens that can, like influenza, for instance, that can trigger similar symptoms. So it's true that most of the resources and interest and attention is around COVID-19 testing. But for instance, if there is a lot of individuals with similar symptoms in the community, even in the presence of COVID, it doesn't mean that influenza or other respiratory pathogens do not circulate, and we should look for them as well. It's very important to maintain this differential diagnosis capacity for other respiratory pathogen on top of COVID-19. Over to you, Sarah.
Thanks, Sebastian. Jane, is there anything from you that you would like to respond to?
No, not in particular. Like Maria, I've been trying to answer questions and provide links to other documents through the chat, and I'm happy to continue to do that. And for any participants in the group to contact me via email if they have some additional questions or would like some follow-up on anything that we've talked about here today. Thanks.
Wonderful, thanks. Celine, back over to you. Anything from your side?
Can you hear me now?
Oh, we can.
Great, sorry for that. No, just bouncing on one of the questions related to, pre-existing testing structures and having built upon that, absolutely. I mean, that's what has been happening since the start of the pandemic, leveraging on existing capacity and taking into account the existing capacity to define, also the testing strategies. So this is linked to, what has been said before in this session. The need to have good testing strategies and we adapting them as time goes, but absolutely in terms of leveraging capacities, and that's been shown with the respiratory disease systems that were for detection that were already in place in countries with programs such as the TB program, and it's been a lot of leveraging of their molecular capacity as well. So yeah, I just wanted to reiterate that of the importance of working together to get this. Thank you.
Thanks very much, Celine. And Marc, I'm going to hand to you. I know you have to go relatively promptly. So is there anything you'd like to address prior to you leaving?
Yes, I just came across, I think, my favorite question, which is, how does testing help reduce the number of cases of COVID? How are they related to each other? And it is true that it doesn't, on the face of it, it doesn't seem to be useful because there's no readily available antiviral drugs that stop the effect of the virus or are as effective as antivirals that we do have for other infections. So it does make you wonder why exactly we're doing all this testing. And they're doing the testing to identify cases because only then can you stop the transmission from that individual to other individuals. So putting people in isolation and giving them the care that they need is critical, normal, good public health, but it also is the way that transmission is interrupted and new cases don't arrive in the populace. So good question.
Great, thanks, Marc. We're at the hour now, so I believe we're going to have to draw this to a close. We want to just say thank you to all our speakers, panelists, and everybody who has submitted questions and taken part in this webinar today. There are a lot of questions, I think, that remain unanswered, and we apologize for that. I think clearly there's a lot of interest, and it would be very valuable to continue this discussion. And maybe, Maria, you want to speak to that, if there are any future plans to continue this. And otherwise, we will, after that, draw it to a close. So Maria, over to you for final comments.
Thank you, Sarah. Thanks for providing this opportunity. And yes, of course, this is not, it's not even the start of a conversation. It's part of the ongoing dialogue that we have, and we welcome further input. We are always aiming to engage. It's not a one-way conversation that we're having here. We serve our member states. We serve the people that are on the front lines, that are fighting against this pandemic. And this situation that we're currently in right now is a catalytic moment to build sustainable systems going forward, to advance the technologies, to work on access, to work on pricing. It's not just about the technologies. Having a great product that people can have access to is really useless for us anyway. And so we welcome the opportunity. I see that there's a lot of really good engagement in not just the Q&A, but the other chat as well, of the CSOs talking to each other. And so we will continue to engage in this type of forum, as well as through the Act A pillar and other avenues as well. So thanks so much, Sarah. And thanks everybody for joining, for your constructive input and collaboration.
Thanks, Maria. So thank you, Marc, and Celine, Jane, and Sebastian, and of course to Zara, who always does an amazing job interpreting. And we wish you really a good rest of the day, wherever you are in the world. So thank you for joining us.